You're year 3, aren't you? Year 3, isn't it? And my task is to give respiratory examination. It's not my intention to give a lecture or anything like that, because there's no point of giving lecture. It was supposed to be demo. So which means you got to perform in front of the patient rather than. But then, like in a time where COVID like this, it's a pretty big, pity for you. So you're not able to perform it, because then the number of patients also not many as well with respiratory problems. And even if you with respiratory problems, yeah, everybody's fear of COVID, isn't it? So we got to be careful not to mix up between COVID and the other respiratory illness. So the purpose of you guys is to do respiratory examination. My plan is to show you three kind of respiratory videos, just only to show you the variety of how you examining children may be slightly different from those who you have what you call examined in adults. So it will be slightly different. Okay, so I'm going to show you what you call the examination from the point of view of proper techniques, and then it's not like they're doing the right techniques, but then we can discuss about commenting on how can it be improved in terms of respiratory examination. Okay, any questions? Okay, there's no question then, is it? Okay, let's do it then. Okay, so the first video, let's see the first video. Are you guys able to see? And let me know if you can hear or not the voice, the videos. Okay. All right. Okay. Let's do it. If you cannot hear, just let me know. Okay.
A respiratory examination now. Hi, my name's Emma. I'm one of the doctors. Is it okay if we have a look at your chest today?
Yes.
Okay. I'm just going to wash my hands. So first I'm going to have a look around the bed and see if you've brought anything with you. Can't see anything, so we'll move on now and look at your hands first of all. Can you see your hands? Very good. Okay, turn your hand over for me. So looking for any hand signs of respiratory disease, particularly clubbing. Could you point your fingers in the air like that for me, and then point them down to the ground and then stick your nails together. Okay, so she doesn't have any evidence of clubbing. Good. Just going to check your pulse. So doing pulse and respiratory rate at the same time. Good. Okay, we'll move on and have a look at your face now. Can you copy me and pull your eye down like that? Put it a little bit more in the middle. So then copy. Okay, very good. So looking for pallor. If you open your mouth for me and stick your tongue out. Okay, good. And no central cyanosis. I'm just going to feel in your neck there. It might feel a little bit funny, okay, but it will only be quick. Okay, so check it as central. Can you pop your hands on your hips for me like you're really cross? Okay, good. For any scars? Okay, sit forward for me just for a moment. Okay, good. No scars there either, and just rest back. Okay, now we're just going to feel for your heartbeat. And now I'm going to put my hands on your chest like that and ask you to take a nice deep breath in for me. Is that okay? Just press your arms down a bit to the side. Good. Nice deep breath and out. And one more. Okay. Good. Very nice. Now I just need to tap on your chest, okay? funny, isn't it? Okay. And now if I could ask you just to take some nice breaths in and out through your mouth in your own time, that'd be great. Perfect. Good. Very good. Okay, just sit forward for me. We'll do the same things at the back. So first the tapping and then listening. Okay, and then if you could do some more of those breaths for me, that'd be great. Good. Okay, very good. Just while you're sitting forward, I just need to check the glands in your necks. Do you mind staying forward for me for a moment? Tell me if it's sore at all, okay? Because sometimes it can be tender under there and I won't be able to see your face, okay? It shouldn't be sore, but... Good, the ticklish. Okay. Go. This and there. Okay, good, brilliant. Just rest back. So we'd conclude the examination by checking for hepatomegaly or displacement of the liver and checking her peak flow and oxygen saturations. Great, thank you very much.
Okay, okay, comment please. What is good and what is not good for the examination, please? I need two-way interaction. I don't want any quiet or sleeping or whatever. Two-way interaction. What is good about that videos in terms of approach to respiratory examination? Guys, are you around listening or not? Yeah, Amir. Okay, so I want to see politeness as well. I don't want to see you being rough to your patient. Okay, so that's good. Okay, one. Any other?
I want to try another one. I noticed that the doctor didn't use her hand to check for pallor or jaundice in the patient's eyes, because for pediatric patients, like it's way better than if we ask the patient or mother. If like baby, if we use our hand, the patient might see like we want to poke their eyes.
Okay, I think it depends on your rapport, basically with the patient. If you're not forming the rapport well with the patient, then they will be scared of you. But if you develop the rapport, you've got some understanding, but still you can achieve, I mean, the skills is you can achieve your findings, or you can achieve the examination by asking the patient to help you out in order for you to interpret the clinical signs that you want to do. Okay? Whatever the key is, I mean, like how you can. Why there's two Rosaini here? I don't know. Okay, so the objective is try to achieve the what you call a clinical examination and ability for you to interpret that clinical examination correctly, not just only perform but also interpret it. Well, I don't want if you're not interpreting it correctly. Okay, So that's number. Anything else? Any other things that we? I mean, I've got a list of couple of lists there. For you, what? Yeah, Mr. Kim.
Doc- Doctor, is it appropriate that we check chest from the back if the patient doesn't hug the pillow and so on because the lung is covered by the scapula?
Okay, I think that's fine. I mean, like in pediatric, if they are cooperative, then that's better to expose, the what you call. But this is a pediatric patient. You need to do whatever you can in order to achieve your objective. So the objective is try to maximize the finding. I always say the goal for respiratory examination is the lung. If you examining the periphery and then suddenly the child start crying and you're not able to appreciate any clinical signs, therefore you miss the goal. You understand what I'm trying to say, yeah?
Yeah.
So the bulk of the what you call the bulk of the most important thing is from the respiratory from the chest from the lung field examination, rather than the periphery looking for clubbing. Clubbing is okay, look for that. But then, like, still, in the instance of like that, then therefore it is important for you to look for the most important thing, and you don't want it to be, children crying and you can't listen to anything. So, in essence, so smaller children, it doesn't matter basically. If they're not cooperative, and as long as you can hear, that's the most important thing. Okay. All right. Any more? Any other things that we can learn from here?
I think the doctor doesn't check the eyes and the mouth because that one also has significant.
Okay. Yeah. Mouth. Okay. What do you intend to do? Let me check for the eye and the mouth. What are you trying to achieve?
For example, I want to see whether the patient have pallor at the eyes.
Pello, I mean, like she did it. Pello, I mean, like Pello, she asked the child to kind of like push the the eyelid, the lower eyelid downward. So that's he did it. She did it. Anything else? What about the mouth? What are you intending to check for?
I want to check for central cyanosis.
Yeah, she did it. Central cyanosis. Anything else? As part of the respiratory examination. Excuse me for a second, I got a phone call. Can you wait for a second? You think Okay, sorry. So where are we? Anything else yang significant in the examination? Oh, is it the same as adult?
We want to see the tonsillitis result of assessment.
Hmm. Okay, but okay. I mean, he didn't do it, but I think any uncomfortable examination, it should be left at the end of the examination. So you should make a remark at the end of the examination. I will do this and that, but I also complete my examination by performing ORL or ENT examination at the end of it. Okay. All right. Anything else? What are the things good, or what? Just now you're talking about what are the things that can be improved. What about the things which are good that he's done?
I think he exposed the patient.
Okay. So please, okay, any examination, whatever you're going to do, any examination, you need to expose the patient. You can't really be examining underneath the clothes or anything like that. So please expose the patient. Good. Okay. Anything else?
She had good rapport with the patient.
Okay. Good rapport. Okay. What do you mean by that? Good rapport.
The patient feels comfortable.
Anything else? Why does the patient feel comfortable?
The patient doesn't seem irritated and is cooperative.
Yeah. Why is it so?
So that when we do auscultation, it's easy to hear.
Yeah lah. She gives instruction. Okay. So if you want to do something, you need to give instruction. Yeah. Let me have a quick listen to your chest. Okay. Let me feel for the for your trachea. Okay. I'm going to feel for your glands, lumps and bumps on your neck. So she said, you can't really be doing examination without saying anything, okay? And then just, nak feel for the apex, just put your hand. Kalau perempuan, you do it like that, you kena penampung kat orang perempuan, okay? Kalau if you do like that. So, give appropriate instruction. Perform it before you say it, Not perform before you say it before you perform, okay? So you say, okay, I want to do this. Okay, can I have a quick, now I'm doing this, okay? Now, okay, can you take a big breath in and out? So give instruction. So it's not like all children will be able to understand or have telepathy and able to understand what you want to do. But on the same token, you want to reassure the patient that what you're doing is not painful. Not like what you're doing is uncertain. Tiba-tiba mari jamah sini. Kena lah, okay? So please make sure whatever you're going to do, whether you are male or female, whatever you want to do, you want to palpate for the apex, you want to do chest expansion, you want to do feel for the trachea, you want to percuss, okay, let me percuss it. I'm just doing it like drumming your chest. Something that to say that, so that the child will be able to understand what you're going to do. Okay? All right, anything else?
The flow is following the flow. I mean like macam it has flow lah during
Okay. Okay, I mean that's okay. I mean as long as you are organized. But this is not the key of it, okay? Because you're doing pediatrics now, okay? So I'm not going to, okay, you see, I mean, the flow looks fine, but this is a bigger child. So let me show for the second one, because you said that the flow is the thing. And let's go for the second one, which is, oh, no. Okay, can you see this? Okay.
I cannot see, doctor.
Sorry?
The video cannot be seen.
Oh, cannot watch. Okay, that's okay. Sorry. Okay. Right here. Okay, just a second. Second. Okay, can you see?
Yes, doctor.
Okay, let's go.
Good. Hey, Adam. We're going to be checking Adam's respiratory system today. Would it be possible to remove his shirt?
Yeah, no problem.
That'd be okay.
Slightly tight.
Oh, you're totally tangled there. There, so we've got some home oxygen here. Oh, and we've got a book, Miffy's birthday. Oh, very interesting. Okay, so just having a quick look around. Okay, is this a baby grow?
It's a vest.
Vest,
Yeah.
okay.
But so I can
Just
push
at
it
least,
down.
at least, okay, so you
It might be easier to push it down rather than.
Oh, I see what you're saying. Yeah, yeah. Okay, sweetheart. You are very active. Am I allowed to know how old Adam is? Dad, how old is Adam?
He's about 20 months,
I'm going to be cheeky and ask what his corrected age is.
which is coming up to 18 months.
18 months, okay. You can see lots of cannulation scars there. Plenty. Hey, are you waving? Are you waving at the pretty lady? Hey, there we go. Okay. I want to try and have a look at his fingers. They look lovely, beautiful and pink. Okay. Oh, you're going to read me a story, Adam? You're going to read me a story? So it's obvious that he's got some home oxygen connected with cannula. Can we see how much is he on now? Dad?
He's on 0.2 of a litre.
0.2. And is that normal for him
It is, yeah.
during the day? Okay. Oh, what's in there, Adam? And I'm trying to have a look at your face. Adam? 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 Who's there? Have a look. So he's beautiful and pink and he's not in any respiratory distress. There we go. Have a look at that book and I have now been having a look for some scars. There we go. And he's got an obvious gastrostomy there. And that was laparoscopically done. I'm assuming. Yeah, so it's not
Keyhole.
keyhole,
Yeah.
yes. Hey, sweetheart. I think I just want to come around the back and see if it's a scar. And he's got a left lateral thoracotomy scar there as well. Perfect, big guy. Should we turn the book so that you can read it? How about that? What about that way? Hey, there we go. Okay, I'm just going to be opportunistic and have a listen while he's happy now. We're going to have a quick listen. What's this? Is there any... we listen to the bunnies first, then we listen to Adam. We listen to Adam? Should we listen to Adam?
Do you want me to hold this up?
There we go. We're very interested. Or should we listen to Daddy first? Should we get Dad to come here?
I can hold
To
his
Dad?
arms down if you want.
And then we listen to Adam. There we go. There we go. What's this? Hey, big guy. You are very active. You've got a nice BCG scar there as well. Okay, you don't like this, do you? Perfect. Okay, I'm not able to hear too much because he's not enjoying that. Can we have a listen to your back now? Should we try the back? Should we try switch you around? So, Dad, let's switch positions and I'll come sit up there next. You look at Daddy.
You see the chat?
I'm going to try and percuss and see if he'll tolerate that. Tap, tap, Adam. Perfect.
Not bad. Lady.
Is that Mr. and Mrs. Bunny?
That's the bear. That's the bear.
Here we go, Adam. You've been a star. To complete my examination, I'd like to have a feel of his tummy. How do you think you'd feel about lying down?
Yeah, you
Would it be
can try
okay? Shall we lie you down, big guy?
that. Ask him.
Here we go. We're going to go sleep. There we go. Any pain in the belly? You tickles. Hey, sweetheart. Okay, big guy. There we go. Fabulous. Just check that you don't swallow. Oh, those fancy shoes, hey?
Take them off. Hang on.
Oh, it's okay. Would he just have some other cannulation scars on his feet?
Yes, yeah.
Okay, comment please.
I think it's good she uses opportunistic approach to check the baby.
I think what is the differences between this examination and the previous video that you've seen or watched just now?
The previous one, it's basically because the child is cooperative, and so the doctor can just follow the flow, the traditional flow. But then for this patient, since the child is less cooperative, so the doctor finds the correct timing to check for the specific.
So you need to be opportunistic in examining smaller infants. So you know that children have got different age group, maybe starting from premature baby to term infant to toddler age group to preschool, school age, and also adolescent. So they all have got different way of deal with things, you know. Because if you are dealing with a child who's probably 9 months or 7, you know, probably will get strange anxiety out of it. So so what you say is opportunity is true and does not need to be organized, but need to know what is the underlying, what is the goal or the top price. Okay, you want to, what is, I mean, if you're doing respiratory, then the most important thing is respiratory lah. It's not about hands, so it's not about mouth. So it's about respiratory, okay? So looking whatever it is in the lung field. That's the most important thing. Okay, next. Anything else?
Doctor, I want to ask question. Is it true that if the baby crying, we fail the exam?
It's not that you fail exam. It's just only you won't be able to appreciate any clinical signs because you're not able to distract the patient. Neither you are able to what you call, use your opportunity to get whatever the most important clinical signs that you need to find. Okay, so it's not about that. I mean, like we often in exam we won't be giving you the child who's crying, but we have to see how you deal with that situation and scenario. Because I mean, like the little you are exposed to children, you look very awkward in terms of trying to play or distract or, you know, perform the examination in front of the examiner. But if you have a lot of exposure, you should be comfortable. I mean, even dealing with that, you know, try to pacify the child or settle the child, you know, or use your resources around you, which are the parents themselves, because they can settle the child or distract using whatever toys or videos or whatever. Okay, so you got to utilize whatever it is in surrounding it, you know, in order to achieve your goals. That's the most important thing. If you don't know, that's a problem lah, because you've never been to the ward and never tried to interact with children. If you interact long enough with children, you should be okay with it. All right, okay. Any more that what she's done better or can do better? No? Did she mention anything about the scar earlier on?
Yes, doctor. She had looked for scars thoroughly throughout the body.
She mentioned about left thoracotomy scar. She mentioned about BCG scar. Wasn't it? Isn't it? So, which means you. What is the key here?
To identify if the patient has done any previous procedures.
So you need to be observant. You need to be careful, because if you are not careful and miss the obvious thing, you are going to look very, very foolish. Okay. So, for example, if a patient has got left thoracotomy scar and you say there's no scar, it looks very bad on your image. You know, it's like you're lying. You know, similarly, when you examine the abdomen, you say there's no scar in the abdomen, and suddenly the examiner show you, oh, there's an inguinal, scar here. Ayo, you look very, very foolish, man, because you did not identify carefully. So whatever it is, you need to identify that particular, is there any scar or not? Because the scar is there. If you're not identifying, because what is the learning from that encounter? Where is the scar? Arwah?
Is it in the inguinal region?
No. This thoracotomy.
The laparoscopic scar. The laparoscopic scar.
The thoracotomy scar. Where is that? Sorry, I couldn't hear.
So is it in the chest? In the laparoscopic scar?
Oh, that's the abdomen.
Yeah.
What about the chest? We're talking about the chest. The abdomen, there's a laparoscopic, and also there's a gastrostomy. So you can see the button there, gastrostomy. There's a gastrostomy. So, but the girl also mentioned about thoracotomy scar, left thoracotomy scar. So where is the scar?
In the lateral chest wall?
Okay. The usual, it's not going to be lateral most of the time. It can be lateral, it can be on the left side, left axilla, or, it can be, but often it is not. Often it will run just underneath the scapula at the back. So refrain yourself from saying anything about the scar until you're sure that there's no scar at the back. So thoracotomy scar, or often it will run from this, from the left axilla going underneath the scapula. All right, okay, just beware. Okay, so what I don't want is you say, oh, you look in the front and you don't see it because it runs at the back. And when you say there's no scar and the examiner point to you at the scar, as I say, you're gonna look very, very foolish, because you're not observing enough of that particular scar, or you're not identifying that scar very well. Okay. Okay. Anything else in the examination? What's the child wearing or having?
Gastrostomy.
Okay, anything else?
Oxygen?
Yes. So you need to be observant. Okay, it's not about the patient themselves, but also things which are around the patient. So when you're doing clinical examination, what are the clues to suggest the underlying problems? So if the patient is on oxygen, so it must be oxygen dependent. They were mentioning that, oh, this child has got some scars on the hands. So this must be a child who's probably premature, maybe, and has been, stabbed so many times, and then leading to scars on the hands. So and the child is also oxygen dependent. So what is the problem that lead to oxygen dependency? Maybe it is chronic lung problems. So issue like that, you need to identify it correctly. Okay. All right. Okay. I think anything else to add up? No. Okay. No. We'll go for the next one. I'm going for the third one. Okay. Just a second. Let me just check first. Okay. Yeah. Let me. Okay. Okay. Can you see? Guys, can you see?
Yes, doctor.
Okay. We'll play now.
Well, I was wondering that. Is it okay to actually just take a step back and have a look at your face?
Yeah, sure.
Is that all right?
Sure.
Yeah? Shall we, how should we go through this? Do you mind helping me? Yeah, just because I don't
I
want
put
to
it
try
I
it
know
there.
it comes out. Okay, 1, 2, 3.
There we go. Thank
So we
you.
get this, we made them specially for him because there's no such a place to do them because he dribbles a lot.
Oh, of
And
course.
he needs one. This most of them, the small and short
They're too
ones,
small,
and
probably.
they get them
Yeah.
here. And now he's learning to put it in his mouth, which is a good thing
Yeah.
because he dribbles on the towel instead of dripping, eat the food all over his clothes. Because I was shouting at him a few times. Because especially when he eat eggs and
Oh,
cakes,
yeah.
and
And that's such a smart top as well. You don't want
they
to get it all
smell.
messy.
They smell. Take this off.
Yeah, do you mind? Thank you.
Everything.
Yeah, if you think you'll be alright, that would be great.
Yes, I'll
Just so I
put
can
them
have a look
back.
at his
Come on,
tummy
darling.
and
Come on.
things.
Show your soft skin. And he's got lovely soft skin.
There we go. Thank you so much. That's perfect. All right.
My daughter said, "Why can't I have a skin like my brother? I'm more hairy than him."
Okay.
She's 5. She's
All
worried
right.
about the hair in her
Let's have a look
legs.
at your hands, my love. Fantastic. Okay. Okay. So some scars on the backs of the hands on the right hand side. You got scars, haven't you?
Yeah.
Yes.
Because this is
And also we've got
yeah. The
scar
drip.
up here,
Yeah, Hickman
which looks
line.
like from a line or
From the Hickman
yeah,
line,
and
yeah.
also one here. Is this
Yes.
from another line as well, maybe?
No, this is when the Hickman line goes from the neck to the heart. So they
Yes.
face the
remaining.
Sorry, my love.
I should become a doctor of this experience.
You probably know lots, I'm sure. Sorry, you all right?
Well, I've got a degree though, but I did psychology and social science, but not doctor. It costs a lot of money to become a doctor.
Okay. Ahmed, would you open your mouth for me? Can you open your mouth for me? Let's have a look. Well done. Okay. All right. Let's just have a little look at your spine. Okay. No scoliosis. Okay. We're just going to listen. You like that wall, don't you? Lots of things to play with. You all right? Oh, let's go that way. Well done. Oh, sorry, we're nearly finished. You all right? Are you okay? I think we're all done now. Yeah. So today I've examined Ahmed, who's a 12-year-old boy. On entering the room, he was in a wheelchair. However, Dad was able to lift him onto the couch, but he was not able to walk unaided. On inspection of his face, he has dysmorphic features, particularly he has a small head with microcephaly, and his ears were low set, had quite a large mouth, and his eyes and nose and lips were quite closely clustered together in the centre of his face. He looked very small for his age, but I'd like to plot his head circumference, weight and height on a growth chart. On the spectrum of his hands, he had scars on the backs of the hands consistent with cannulas. He also had a scar on the right side of his neck, and also which was about 1 inch in length, and also a scar just above his right nipple, which may be from previous Hickman lines. They're both well healed. He had normal heart sounds and a clear chest, and his tummy was soft. In summary, he's a 12-year-old boy who appears to have developmental delay, small for his age with microcephalic and dysmorphic facial features, but he did not have any other notable skeletal abnormalities or scoliosis. So in summary, my differential would be that this boy has a congenital syndrome.
Okay, all right, okay. How is it different from the last two? Guys? Am I talking to somebody? Okay, all right, okay. Anything else? What's the differences between these three of, you know? Anybody?
She was actually talking with the patient, in which she asked the patient to respond to her and wait for him to respond to her, and then take the opportunity to perform the examination.
Yes, that's what I want to see. Okay, I want to see that even though the patient may look having, you know, learning difficulties or handicap or whatever, you are purposely need to show that you are respecting the patients, performing according to your professional conduct. You know, if you want to palpate or percuss or whatever, do the same. Even though the patient may have a syndrome and may not be able to understand you, but you're going to show the same kind of attitude, whether this is a normal child, a baby, or a child with mental disability. All right, anything else? So it is, yeah, Anis?
Sorry. For me, I think like the doctor, she did very well. She was compliment the patient after everything that he did. For example, like when he asked for the patient to show his hand, he did well. She said fantastic. When open the mouth, it's like well done.
Okay.
Keep complimenting and give positive words.
Thank you very much. You have what you call identify a few bits which is important. So when you're examining a child, not only you're going to identify things, going to get them to cooperate with you, but also say good words to the child. This is good. Wow, excellent, great, perfect. Wow, you are very good. You're a strong guy. Okay, so things like that you need to give a positive words or remark to the patient in order for you to get them to cooperate with you. So well done. You have identified good things that need to be done, especially when examining pediatric patient. Anything else? The thing that I might want to comment from these 3 videos is for you to, like when you're starting an examination short cases, I like you to observe for maybe 15 seconds before you go and do all the examination. So a lot of the time people just, please examine this child's chest. So you go straight to start with hand and everything, you know. Take your time, stand back at the end, look at the patient and look around you to see if there's any clue that might help you to picture the problems to the patient. Because sometimes you might not be able to identify things, but then like you might visualize, oh, now I can see that this patient is having a spacer. Oh, it must be asthma or something like that. So I anticipate I should hear some wheeze, some, you know, some sort of, if there's an infection, there's antibiotics around it, you know, or IV drip or whatever lah, okay? So just beware, you know, beware and be careful when you're approaching the child. And each of those things, I mean, the patient, each of those cases just now, it showed that the parent, you know, took off the top of the child in order for you to appreciate. Although in the cases looks normal, but then you want to see if there's any clinical signs of distress. If you have saturation, you want to do saturation, isn't it? Because this is respiratory, dealing with the lung. And if there's any lung problem, then it might have an effect on the saturation. If you have it, you can comment on it. Because I mean, like if the saturation is below 90s, then you might be thinking, oh, is this correct, or is this child got cyanosis or not? So you want to make sure that everything is in line in order for you to support whatever you are going to say later on. Okay. Anything else, guys?
Doctor, I want to ask regarding tactile parameters and vocal parameters. It's like if the patient able to, if the patient able to speak, is it a must for us to do forward?
Okay, I think depending on what the purpose of it, okay, because what are you supposed to be doing? You're supposed to be doing inspection, palpation, percussion, and auscultation, isn't it? So if you're thinking that in your, you know, if there's any clinical signs to suggest of compromised airway, you should be doing it lah, okay? If you if there's no compromise of the airway, the child is breathing, unlikely you're going to find anything abnormal. Unlikely, isn't it? But if there's a compromised airway, it might be because of consolidation. Then tactile parameters and vocal parameters will be different. Obviously lah, okay? So in order for you to support whatever you're going to do, I mean, you need to look at the child. But obviously, it will also depend on that child age, because if it's tactile vocal parameters less than 5, they might not be cooperative. You know, so you might not need to do it because they're not going to be cooperative. You know, so the key always is to listen and try to appreciate what are the clinical signs on auscultation. So if the child is bigger enough, more than 5, then they are cooperative, then obviously you need to do it lah. But if you think that, oh, you couldn't find any other abnormalities, by all means, you don't need to, because it's going to be normal. You can, basically. It's not wrong to do it, but it's going to be normal, isn't it? Unless if there's any other specific issues, you know, related to it. All right, okay?
Doctor, just one more question. For respiratory examination, do we need to check for the respiratory rate and also the pulse rate?
Yes, obviously, yes. Because this is respiratory, isn't it? You should be, I mean, like in the cases that were shown, they didn't do, as I said, I mean, like you should check for vitals, you should check for saturation, you should, if it's available lah. You should, because we're doing respiratory. We're not doing GI, we're not doing musculoskeletal, we're not doing hematology. But we're doing respiratory. So when you're doing respiratory, then you need to state the most important thing, which is respiratory rate. And that might indirectly affect the heart rate or pulse rate. Okay? And saturation is part of the respiratory. Definitely. Anything else? Okay, if not, then I'm going to just quickly go through this. Where is that? Quick one. Okay. Yes.
Doctor, I have a question.
Yes.
For the for the respiratory rate, right? Do we need to calculate full 1 minute, or can we do
obviously.
15?
Obviously, 1 minute, you can't really be calculating only 15 seconds because it's not going to be regular, isn't it? You can't. I don't think so. You need to go for 1 minute for it. If it's what you call heart rate, pulse rate, then it can be done 10 seconds or 15 seconds or 30 seconds. Even 6 seconds will be okay for me. If it's regular So beware. I mean, you should count it for 1 minute because that's what you need to do. You can't really count it for times 4 or times 2 because it might be erratic, you know. So I'm not. Anything else?
Thank you, Doctor.
Okay. So just beware cases that you might come up in the exam. Some of those, okay. And I also mentioned that there are different age group, which is going to be challenging. The most important is try to build the rapport and also make sure good exposure and listen to whatever the instruction given to you, whether it's examining the chest or examining respiratory systems. Examining chest may be just on the chest only, not respiratory systems. But if they say respiratory system, then you should start with the hands and everything, okay? Observation, I mentioned to you, look at important for you to observe before you want to listen to the clue of the problems. If the child is, not failure to thrive, then you kind of know we're doing respiratory examination on the child is failure to thrive. So there must be some other underlying respiratory disease that might affect the respiratory, that might affect the nutrition of the child. Look at it as deformity, look at it as scars, and look at surrounding it. If there's any clue that might be related to the case itself. So what's the case? You know the normal heart rate or respiratory rate. This is important for you to determine whether this child is bradypneic or tachypneic or normal. And also some different patterns of respiratory patterns, which I'm not going to do it because these are some of it extreme because of end of life or because of metabolic problems. And I think last time they were mentioned about different devices, about battery mask. And we often use nasal cannula. So the nasal cannula that we often use. High flow, we often use as well. Simple mask don't use. Venturi don't use. Partial rebreather, no, not really. Non-rebreather, yes, we do. Most of the time. This is an oxygen concentrator. Sometimes you might see this. This is a head box. Baby might be on the head box oxygen to supply oxygen if they have underlying respiratory problems. Okay, high flow nasal cannula. This is what you use commonly. And then something that you might want to see is that if there's any drugs related to the underlying lung problems. When you look, you want to see if there's any acute or chronic signs. Clubbing is one of the most important things, but you need to know about the differential why the child has got clubbing. Similarly to the face as well, sometimes the face looks odd. For example, like this baby here, I show on the right bottom in a cube, and it looks scaphocephaly, okay? Scapho means elongated. And this is as a result of the baby has been in NICU for a long period of time and sleeping on one side like this. And this is a child with maybe Pierre-Robin sequence where the jaw is a little bit small and the child might end up with some airway issue as a result of big tongue. Similarly to other conditions, may be related to the facial and bone, and that may restrict the airway breathing. As I mentioned earlier on, this is a thoracotomy scar. It is underneath. So if you look in the front, you might not see it at all. The other scars, maybe this is mid-stenotomy. This is more like number 2 is more like if you have a pacemaker box that you want to put it over there. Number 4 is more like a defibrillator. You put it underneath the ribs. And number 5, I don't know what it is. I've never seen one of these. But thoracoscopy number 3 is much more common. Don't forget about Harrison-Salkers, and this is pectus excavator, okay? Where the sternum is depressed. Excuse me, sorry. Depressed, but then the child might be okay. And some of the things that you look for, I mean, what is this? Anybody? Anybody, what is this?
Is this Harrison-Salkers, doctor?
Mana Harrison-Salkers? Look it carefully. Absence of pectoralis major lah. Look it. There's no pectoralis major on the right side there. Okay. The nipple is there on the left side. The front one, there's no pectoralis major. So look at it. And this is not Harrison-Salkers. Okay. This is the absence of pectoralis major muscles. So be careful of what you look for, because I mean, like some things that might, they call it Poland syndrome. Yeah, there's no pectoral muscles over there. Okay, beware. Similar, you want to do chest expansion, may not require in smaller kids. Chest tactile parameters may not require, only in older kids. Okay. Percussion also, make sure when you percuss, you can see that they percuss horizontally, but between both lung fields. And you need to make sense of whatever you're going to find towards the underlying problem. You cannot just say, okay, percussion is hyperresonant. The underlying problem is pneumonia. Oh, that's not on lah, because percussion in pneumonia should be what you call dull rather than hyperresonance. Okay. Auscultation as well, I don't think there's an issue. You can test on it. Abdomen, if there is anything related to the lung, it might lead to abdominal issue. ENT, don't forget. And sometimes when you have a bigger child who basically has got chronic lung problems, they might be affected. The other system that might be affected is puberty. Okay, I think that's it then. Okay, nothing more than that. Any questions? Okay, no question?
I think no question, doctor.
All right, okay. So if that's so, then we can stop here then, okay? All right. Thank you very much for your attention.
Thank you, doctor.
Thank you.
Thank you, doctor.
Thank you, doctor.
Bye.